Hello, and welcome to this week's episode of Ladies, Let's Talk About It. I'm your host, Dr. Denise Jagru. I'm a board-certified clinical specialist in women's health physical therapy. On today's episode, we'll be talking about the conversation that nobody had with us about perimenopause and menopause. And we have a lot to discuss. And here to talk about this with me is my very good friend, Amy Hill Fife. She's also a pelvic floor physical therapist. And a funny story about Amy and I is that we've known each other for years. We work for the same hospital system, and this hospital system in this country has different locations, different facilities in different states and different cities. So I work in the one in Manhattan, and she works in the one in Grand Junction, Colorado. Do you also live in Grand Junction?
I do. Mm-hmm.
Oh, okay. So she's from Colorado. We've known each other for years. We send each other Christmas cards. We send each other gifts. That's wrong. She has sent me gifts. She has sent me chocolates, and because she knows I love chocolate. And then we know a lot about each other's lives. We've collaborated on many projects and programs within this hospital system, but we have never met in person until 2 hours ago when I picked her up to bring her here. So this is so special to be with you in person. By the way, every time you open your mouth, I learn something. You are absolutely brilliant. I am always in awe of you. I feel like I learn so much from you every time. Aww. And you are my shiro in the world of pelvic PT and just in life. Aww. And so I'm so honored that you flew out here to do this with me. I love having you here. And thank you so much. And thank you for discussing perimenopause and menopause with me. And I know I'm not going to do it justice. So I'd love for you to introduce yourself.
Okay. Oh my gosh. Well, I feel honored. Thank you for having me. Yes. So I guess I can look here. So Denise and I, like she said, we just met 2 hours ago face to face, gave each other hugs. I am a pelvic physical therapist, board certified just like Denise. I have been a pelvic PT for 26 years and also orthopedics as well, manual therapy. I'm a sex counselor, and I have a very strong interest in obviously pelvic health. This is what I've been doing, my passion forever, as well as working with women and men who've had trauma. So it's been amazing. And obviously we also work with a lot of people who've been through menopause, perimenopause, menopause. And now that I've been through it myself, I feel like I even have more of an insight into what it's like. So it's just really amazing for me to be here. And it was so fun. And I just said, oh, I want to be on your podcast. You said, come out. And here I am.
Yeah, you decided it in like a moment. It was like a Monday morning. And like by Monday afternoon, you're like, my flight is booked. I was like, oh my gosh.
Maybe a little impulsive, right? Maybe a little bit of that ADD that we talk about.
Yeah. But I think that's how some of the best decisions are made.
Yes.
In the moment when you feel it. So I'm so happy to have you here.
Oh, thank you. Thank you. Thank you.
So today we were talking about perimenopause and menopause. And one thing I want to clear up is I think people kind of use the terms interchangeably and they just say like, oh, I'm perimenopausal or I'm menopausal or whatever. But I want to just clear up the stages. So perimenopause is a transition stage. This can last for years, right? This is when your hormone levels are like fluctuating, the estrogen is decreasing. So you may have periods, you may not have periods. But for you to be in the menopause phase, you have to be without a period for 12 months. So if you go 11 months without having a period, and then in the 12th month, you get it, you have to start the count all over again. So you're not fully in menopause until you're without a period for 12 months. So during that perimenopause period, you're having like lots of experiences that are unpleasant, because what I realized, and this is when I was going through fertility treatments, I was having endometritis, which is inflammation of the uterine lining, and they put me on a medication that blocked my estrogen production. It's Depo-Lupron. And it put me into instant menopause for 2 months. And it was the worst 2 months of my life. I've been teaching about menopause for a long time, but to experience it and without like kind of a gradual like journey into menopause, it made me really understand that estrogen like plays a part in everything. And I didn't realize it was everything because, you know, I was having fogginess, right? And like joint pain and like issues with my balance. And like, you know, we were talking about this on the way here, like I don't honk my horn, and like I honked my horn. Like I felt mean because I honked my horn at somebody. Like I'm a very nice person and I'm not the typical New York City driver. And I felt like really like, I don't know, like right now, I feel like I'm in the phase of like, I'm a perimenopausal a-hole. Like every like 72 hours, I have like a periodic catastrophic mental implosion.
Yes.
And when like 72 hours goes by and like it didn't happen yet, I'm like, it's time for one of those again. I don't want to be around me when it happens. So what are some of the experiences maybe you've had with like, during that period?
Well, I think what I really want to talk about as you're bringing it up, sort of that the ups and downs, you really feel like some people cry, some people get more depression in the perimenopause stage for sure. And so let's talk about mental health, because most of us think, and most of us have heard that it's, back in the day, because I'm a little bit older than you, but back in the day, it was the change, right? And so now we can actually say perimenopause and menopause. And let's just kick it off with mental health issues, because the highest rates of suicide for women, for females, is between the ages of 45 and 55. And that really means that something is going on during that time. And what would that be? Well, that would be perimenopause and menopause. And perimenopause can last, like you said, years. It can be 10 years. And so if the average age, and I think this changes a little bit, but 52 or 53 years old, to go through full menopause, that 12 consecutive months without having a period, and we can have 10 years prior to that. So we're looking at people going into perimenopause at age 42 and maybe starting not to feel very well. Maybe they don't even have a hot flash, right? Because we all hear about the hot flashes. It's all about having the night sweats, but that's not what it is all about. And so I really think it's important we get the message out to women and their partners and their family members, et cetera, that, hey, let's be on the lookout for each other and of what might be going on. Our anxiety starts to go up. So when those estrogen levels start to come down, or like you said, they sort of go up and down during perimenopause, slowly declining for sure. That can affect so many things for our mental health. And I think it can be very, very concerning that is not addressed and it's really not known. Mm-hmm. So that's one thing for mental health. I definitely want to say that's why you feel like you want to lay on your horn now, maybe where you didn't before. Now, maybe I would be a Brooklyn, like I would be on my horn all the time if I was in New York, because that's sort of my personality. But it may have gotten worse. Or for me personally, and everyone's going to know this, my depression got really bad, and that was scary. And I have been in pelvic health and women's health for 26 years, and I still didn't really recognize what was going on in myself. And that was during my perimenopause stage. Mm-hmm. And just the other thing is, some people may go through those perimenopausal stages when they're in their 30s. So we have to really pay attention and not totally put a time frame on it, even though certain years are more common than others. Mm-hmm, so
for sure. Thank you for pointing that out. It's so important. Mm-hmm. I know I've definitely been having a hard time. I had my little one, later in life. So I went from like postpartum depression, then like right into perimenopause. I just haven't had a break with like, these mental roller coasters. And I feel very bad for my family who was around me all the time, has to deal with me when I'm going through this. But like, like when I was able to kind of put a label on it and be like, oh, that's right. I'm like, this is what I'm going through. Mm-hmm. It just like, it helps you to realize that like there are options out there. There's resources for you, which we'll talk about in a minute. Mm-hmm. But, before people just didn't talk about it. No. No one wants to talk about like leaving childbearing years and like, aging and, it's becoming a little more mainstream also because I think some celebrities are talking about it more.
Yes.
Like Halle Berry talks about it. She calls it her second act. And she's just making it more like mainstream conversation, where before it was just so taboo.
Oh, completely taboo.
Like even just saying like the change, like no one wants to even like give it a name,
Right.
But I wanted to talk about some of the other changes that can happen because people think hot flash and people think moodiness. I think like those are the two things. But, like I said, you can have issues with mental clarity and your focus, right? So like I have a lot of issues with word recall.
Yep.
I feel like I'm always like, and it's something I could use every day, like it's not something like obscure that I haven't thought about in 10 years. It's just like something just random.
Like, where's my purse? Right. But you can't remember the word purse. Right. Or you walk into your bedroom and then you wonder, why did I just walk into my bedroom?
Yeah, oh my God.
Because you're looking for your purse and you also can't remember the name purse. Yes, the word purse.
The amount of times a day that I'm in front of I'm like in my fridge with the door open, blank. Like I find myself there so often. It's probably like my most frequented like spot in the house. I'm like, why did I come here? What was I making? I don't remember. But I have a kid. Like I should just be more on top of things. Decrease blood flow, decrease, collagen changes. Like you can have problems with like just spraining and straining things more, like instant joint pain that didn't exist before. It's not like an old injury that you had. You could just have achiness in your knees all of a sudden. Pelvic floor muscle changes, obviously. Nervous system sensitivity, like just being like just more hot, right?
Yeah,
like more like volatile or like just easily triggered, right? Urinary issues. So there's a whole name that they're giving to it now called GSM, which is genitourinary syndrome of menopause. So you can have issues like vaginal dryness, issues with like urinary leakage and stuff. But now they have what I want to talk about is this study that happened 20 years ago. And it's funny because I was getting my hair done and this woman was talking about it and she's like, well, I didn't do estrogen, when I was going through it because like estrogen gives you cancer.
Right.
And my mom, she ends up getting breast cancer because she took estrogen when she was going through it and she didn't know that like blah, blah, blah. And I was like, she goes, because of that study. And I was like, this is literally what I'm talking about today because there was a very poorly done study 20 years ago. And the women who were included in it were not, selected properly, where 2 of them developed cancer, but they were already very high risk for cancer. And they were like way post menopause. Like they shouldn't even have been included in it. But the messaging that got out from that study was that estrogen causes cancer. Right. And so women probably for the past 2 decades have not gotten the care that they could have gotten because they just think, estrogen causes cancer. And estrogen got this black box label. Warning, meaning like, it can cause cancer. And it was only very recently that they were able to take that label off and do what, a lot of doctors knew this whole time, that like there are ways to safely administer estrogen in low therapeutic doses in different ways. Like if you are just experiencing like vaginal, genital urinary symptoms, you can have like a local cream, that's being locally absorbed. It's not like systemic. And even if you are taking something systemic, it's not like these high dosages and it can be administered through like dermal patches and stuff. So like, I think the messaging that got out and kind of like stayed, like embedded itself into like the in the mind space of like society is like estrogen is bad, And I think like, now we're finally trying to reverse that and let women know like there is help, like there are resources for you and there are ways to get relief from your symptoms.
Absolutely. What's interesting about that study is I was living in California at the time and I remember where I was when I heard about the study and I thought, well, this isn't going to be good. Right. And so then what happened with that generation of women is that they all were taken off of their medications. And a lot of them were on Premarin. So that was the estrogen back then that they were using. So things have changed with the type of hormones that we're using now. But yeah, so then what we're seeing now, what Denise and I are seeing is that there are women that are having a lot of osteoporosis, osteopenia, maybe early onset with some of that because estrogen helps with bone density. And so, femur fractures or hip fractures lead to sort of a major downfall and sort of a decline in health once we have those, depending on our age and if we have severe osteoporosis. We also, like you talked about with the collagen. So I think this is also important to talk about with postpartum too. So maybe we'll jump that in, even though that's not perimenopause technically. So vaginal dryness. So the vaginal tissue has estrogen receptors in it, and it keeps the estrogen keeps everything plump, and you have lubrication, and the tissue stays healthy. And so what can happen just with the vaginal lining is it starts thinning out. It gets really fragile or friable. And I've talked for years about it, even though I'm not a physician, but I've been doing this for so long. And so have you. I would say, yeah, you're just that tissue, you're getting microabrasions in it. So then if we get these like tiny little tears, it can also set us up for having, a vaginal infection. We also know that estrogen keeps the pH of the vagina in a certain state. So our bacteria is balanced appropriately. So women do tend to get more infections vaginally when we don't have that local estrogen. Sometimes it can work systemically. Like you said, we can have a transdermal patch or a cream that you rub on every day. And oftentimes that's enough for some women, but other women need more of that local vaginal cream that you use 2 to 3 times a week. And like you said, these are lower doses. And of course, physicians, pharmacists, they're the ones who set all these doses. And then that is the genito part of genitourinary syndrome of menopause, which is a new term. What do you think in the last 2 years? 2 years. That did not exist before. And so the urinary part of it is that we have more bladder issues because we think that there's also that thinning type of issue going on around the urethra or what have you. The bladder gets more sensitive. So we see women that have a lot more urgency. The pelvic muscles are also weakening because estrogen, and I also think some testosterone that someday we'll be talking about. I know there's one physician right now. She's really, really talking about testosterone in women, and I love it. We can talk about her name if you'd like. But anyhow, so the estrogen helps with both the urinary symptoms as well as the vaginal symptoms. And again, that's a new term that didn't even exist. And so now we have that part of it. So if we talk about the GSM, we talk about bone health, you talked about joint health. So we have estrogen receptors in our joints. And yes, so when you went on the Lupron during fertility treatments, you noticed it immediately. For perimenopause and menopause, it tends to be more gradual, but you sit here and you wonder, like, why do I hurt? What is happening? And your joints can hurt because we don't have those estrogen receptors or the estrogen going to the receptors, and then you get the joint pain, the inflammation, et cetera. And then talking about the brain fog, which we've both sort of talked about, that just mental issue where you cannot remember something at work, or I've noticed I need to go back to using my calendars a lot more and really making sure I know what's on my calendar. And like you, I'm also an older mom. I think it's important for us to talk about that too, that I didn't have my son till I was 38. And so I was very close to starting to go into perimenopause already. And that's also an issue for people that are either some people have large families and they may have babies until they get to perimenopause, menopause. And then there's a lot of us who are having children older, and then it's not recognized. Like you said, you go into this postpartum part of it, which again, if you're breastfeeding or hormones, estrogen's low, same thing. You could have the same perimenopausal symptoms, right? Pain with intercourse because of that friable tissue vaginally, bladder issues. A lot of physicians used to tell our patients, I don't know if you remember this, but they'd say, oh, your pain's going to go away in 6 months. Well, yeah, it sort of did, because they would stop breastfeeding and then the estrogen would go up, tissue would become plump and healthy. And then if they were having sex, when they started having sex again, it wasn't as painful anymore. And that's the reason. So I even have a few patients where they are being prescribed a little bit of vaginal estrogen postpartum.
Okay.
Yeah. I didn't, I think that's sort of new too. Okay. So we'll get back to perimenopause. Sorry. What did we miss?
So talking about like the vaginal dryness and the friability, this leads to sexual dysfunction. So, and people don't like to talk about this either, right? So, and this is like our thing because we're pelvic PTs and we deal a lot with like sexual dysfunction, both for males and females. But, it can affect a lot of things. Decreasing estrogen can affect like desire, right? Decreasing libido, arousal takes longer. There's different stages and phases of like orgasm. And so like that changes and phases plateau and like take longer to get to and take longer to like recover from. There's, there could be pain during penetration when the tissues are not as they're not as
full of blood and opening up. You may not have as much lubrication. And then, yes, basically the lubrication and the tissue's thinner can be if people are not taking any hormones or not using any hormones. Yeah.
So for us as pelvic floor PTs, we're not prescribing these things because, the OBs or the GYNs would do it. But there are ways that we work with patients to help with these symptoms and to get them back to feeling more like themselves and being intimate with their partners or themselves. And so there are lots of tools that we work with to try to like stretch the tissue and get the tissue to just be a little more flexible and have a little less tension in it. There are like stretches and exercises that we teach our patients. The physical part is part of it. There's also like the whole mental health component of it. So it really needs to be like a whole like process, right? And a whole therapy process for the patient.
Yep. And a whole person approach. So with that, I think what starts happening again, because no one's been talking about it, is that people start having, maybe they start having pain with sex and they're not really sure why. The women are having pain with sex. And then you have a partner, if it's, male-female partner, so a heterosexual couple. And then the husband may be like, oh my gosh, I don't want to hurt her. So then we get both people sort of wondering what's going on. Women aren't sure what's happening. They don't know why they're having pain. And then we start getting into a cycle of, oh my gosh, I don't want to do that again because it's painful. And so then I start thinking about that it's painful. And then my desire starts going down because I'm afraid I'm going to have pain. And you start getting to relationship issues as well. And so that's just another thing that can start happening. So when we have the hormones that are shifting, we see all sorts of things that may start as a physical issue and then start becoming more of, like you said, the mental health issue because it's painful and then it's not any fun and the tissue isn't filling up with blood. The clitoris has the same tissue as a male penis and it fills up with blood. People don't realize what a larger organ it is. And so the same thing that we can see men with their hormone issues, they could be starting to have some erectile dysfunction. And women are having the same thing, but we don't see it. And it's not as readily evaluated, I would say. And so then it's more difficult to feel the pleasure and maybe, like you said, reach that plateau or the climax and really enjoy that part of it. And so it becomes a big struggle for people, not just painful for women, but a struggle between couples to really enjoy that time of life. And so it is something that can be talked about. Now, when we talk about like that pain cycle, so we see a lot of people with pelvic floor muscles, 26 muscles, sort of depends on who you talk to about how many muscles, but they start clenching up, get tight, you can get into spasm. And I was listening to you earlier, Denise, so she was talking about how the muscles, you can hold tension down in the pelvic floor muscles, and it's just like having TMJ or holding tension in your shoulders. And so we can teach people how to get those muscles to relax, elongate, using massage tools if we need to, teaching self-massage, using mindfulness techniques can help. And we also, like you mentioned, we work closely with the physicians, pharmacists, lots of nurses, lots of different people to really find the right help for people that are in this stage, for the women that are in this stage, to recognize what's going on and to become aware, I would say. Don't you think? Yeah.
Sure.
I don't know if we're going to talk about this, but cardiovascular health. Can I jump into that real quick?
Of course.
Okay. So another thing that is very significant for women, especially when we go through menopause, is cardiovascular health. So that's your heart health, basically. And estrogen affects heart health. And so we get cardiovascular disease at very high rates after we go through perimenopause and menopause. Well, your heart pumps blood everywhere. And so in the stages of the sex cycle, right, you have desire, then you have physical arousal, which is where the blood flows into the muscles. Same in men and women. So pelvic floor muscles sort of get ready to have sex. And then you get lubrication. Now, if we're starting to have heart issues because maybe we haven't been treated with it's not always about hormones, but it is, our estrogen levels are lower, then that can also affect the blood flow. And we can see some of that happening in men too, with their changes in their heart health, that they also may be starting to have erectile dysfunction because the blood flow is just not what it used to be and what it needs to be. So I think that is also an important thing to talk about, especially for women, that gets overlooked all the time, is how our cardiovascular health is affected when our hormones change.
Yeah, super important. And I think sometimes that gets maybe more attention because maybe someone's going to like the cardiologist or primary care will send them for that. But other quality of life issues or intimacy issues don't get as much attention. Right?
Absolutely. Yes.
So I wanted to make one point about what you said before. The clitoris is, and we're all very comfortable talking about this because we're like pelvic therapists and we talk about this all day.
Right.
But it is very big. And this is something that they only realized not too long ago because we only ever can visualize the clitoral hood and the head of the clitoris. But like it has bulbs and it has legs, by the way. So the clitoris is actually a very big organ that doesn't get the attention that obviously the male organ gets. That's number one. Number two, talking about how, we're both certified sex counselors. So we talk about the intimacy and how all of this affects the intimacy and the relationship. So I treat a lot of the male patients in my hospital with, erectile dysfunction, and they all kind of say the same thing. Like, they started experiencing, issues with being able to obtain or maintain an erection. And it happened at the same time when my wife was experiencing the change. They say the same thing. All of them say the same thing. So like, they're like, my wife and I, like, we're not like communicating as much and we're not like being intimate. And like, if we start, it doesn't last long because like, it's painful for her. It's like, I can't perform and there's so much pressure, right? Like for, they don't want to lose each other. There's like, and it just leads to so many issues within the marriage and within, like their intimacy and connection and stuff. So this starts off physical, but then it ends up very,
interrelationship issues. Yeah, so things change during that time, right? I mean, definitely the change, but things with partners can change as well because we can start thinking about this time of life that it can be different, and maybe we have to go through a phase, a season of what can we do differently until we get things figured out if we're having pain or if we're having mental health issues. And if we want to maintain that intimacy with our partners, it may look more like going more on date nights, holding hands, seeking more of the pleasure rather than the climax part of sex, and looking at it differently. I have people who say, we just are sort of blah and we don't really want to do anything. And so we talk about scheduling sex, which sounds very, very boring. For people who are like, I don't want to do that. We just used to be able to, like, whatever, it would just happen. Well, when we're tired, we're not feeling as good, we have joint pain, what have you, right? Sometimes we can look at it like, oh, when do I feel the best during the day? Or maybe there's like a Friday where we can schedule an afternoon delight and it's something to look forward to. And now it sort of becomes this thing between two people. So there's a lot of different ways we can help with that during perimenopause and menopause as well for that sexual intimacy, and then focusing a lot more on pleasure and just changing things up just a little bit and knowing that we don't have to suffer through it and be miserable the whole time. So, yeah.
One thing I would like to see is preparing like women before, instead of trying to like people scramble for information or just being lost, in it and all the symptoms and all of these issues with like partners and everything. Because I run a menopause group in my hospital, and what everyone says, every woman is like, I was blindsided by menopause. I was bamboozled, and like they just don't have information. This is something that the physicians, the different GYNs have been saying, like, if you're going to run a group, like, can you have as many like resources, and we could start it early. We started having it if they were like, they were only pitching it to the women who are already in menopause. And I'm like, no, like open it to patients who are younger because they need to prepare. They need to understand what's going to happen. And I feel like we're just lacking that, in society, like just with the education and like the resources for women to be ready to understand. And like, I feel this happens twice. Like, people don't understand what happens like postpartum.
Right.
Like, I feel like that is just like this, storm that comes on, and like people are just not ready for that. And then perimenopause, menopause. It's like, you go into that and people are like, I didn't know this was going to happen. And I feel like we just need to do better as a society on educating, and providing resources and having all that information available so people can be ready.
Well, and this is exactly what you're doing with this episode of the podcast and in general with podcasts. So you're doing a huge service for women. And I would encourage women who are listening to this or watching, if you're watching, is when we talk about things like the clitoris as an organ, go look it up online. Look up an image and a diagram so you know what it looks like. And, you can do some of your own research online after just getting this little introduction into what's going on. And again, bring other people into your world for your healthcare providers. So have the discussion with your OBGYN. If the OBGYN isn't up and educated on it, or even your primary care doc, it's fine to seek someone else, a second opinion, possibly. If you have pelvic floor PTs in your area, find them because they are very helpful. And then become familiar with the signs and symptoms of perimenopause, menopause before they start. So again, it's not just about hot flashes. It is that brain fog. It's the word finding issues. It's the moodiness, but really not understanding why your emotions are one way or the other, but just recognizing that, like, oh, I think this is what is happening. My tissue, it feels tighter down there. It's more painful. What's going on? And then of course you may have the night sweats and the hot flashes as well. Oh, you know what? We didn't talk about heart palpitations. That's really common. So then people think they're having severe, heart issues. But finding your healthcare team beforehand and asking them, what do you know about perimenopause? What do you know about menopause? What should I be looking for? And putting that team together. And then, of course, also getting your family on board and educating them. And then maybe you talk to your sisters or your aunts or your mom and your grandma, whoever. So they also are aware of what's happening. Mm-hmm. So I hope you guys you're watching this episode with Denise. She's awesome.
So these are all great recommendations. Talking to your doctor, finding out what is safe for you in terms of, treatments, options, resources, seeking out the help of a pelvic floor PT, communicating really well with your family, your intimate partner about what you're going through, knowing that it's normal what you're going through. You're still a good person, even if you honk your horn, and that there is help out there. So, don't take it out on yourself, and know that like millions of women, billions of women in the world are going through the same thing. Mm-hmm. And is there anything you'd like to add?
Yes. I think that there is a group of people who do not get talked to at all about menopause, perimenopause, menopause, and that is a same-sex couple of women, lesbian couples. I've had so many patients come to see me, and I don't know what it is, but it is almost like they're completely ignored. No one's talking to them. And you're going to have two people that may be going through similar things at similar times, depending on their ages. And so I think it is important that we really recognize that, and that if women get to a certain age, for age-related menopause, they're going to go through menopause, and it does not matter who they are. So same-sex couples, lesbian couples, it's really important for you to also put together your healthcare team, talk to each other if you're in a relationship, and talk to your friends. Again, talk to family and make sure that you guys are all aware, because they get overlooked. I've had so many couples come to see me and they've been overlooked. They're like, no one ever talked to us about this. It's just like we don't go through it. Mm-hmm. And they do. So that's one thing. And then, oh gosh, what was I going to say? Oh, yes. Okay. So the other thing I want to talk about is that women who have hysterectomies, let's talk about that real quick, because they can be thrown into, well, depending on what's going on, perimenopause, menopause. If their ovaries are removed, then for sure they're going to go into, I call it surgical induced menopause. And so you could be 28 mm-hmm. and have that happen. Mm-hmm. And once again, a lot of women didn't get any treatment. They didn't get talked to. They didn't know why they were having difficulties. And they're 28 years old and have no idea. So once again, it's really important to realize that menopause can occur at different mm-hmm. ages mm-hmm. of life. What do you think about that?
It's funny because people, my friends and people I talk to who have like really terrible periods or like, and they don't want to have children and they're just like, oh, I just want to get rid of my uterus. Just take my uterus. And I'm like, there are things that can happen that you're going to deal with a whole other slew of issues. So like, for now, let's keep your uterus and like just try to find like, treatment options for you. But like people think like, oh, I just want to take this out,
Right.
just get a hysterectomy and that'll solve my problems. It's just kind of like handing you another set.
Right.
Yeah.
Just being gather all your information, get all your healthcare team if you're going to make those decisions, because sometimes it is the right thing for certain people, and recognize that there are other, like you said, there's secondary issues that come along with that. And that's okay as long as you're aware and you're just not left in the dark by yourself, not knowing what to do at 28, 30, 32 years old when you shouldn't be in perimenopause or you're too young, which is what a lot of women are told too.
Yeah. True.
So, okay.
Well, thank you so much.
Thank you
for this
so good.
fantastic informational session. I hope you all learned something, and I hope you at least have an idea that you're normal. It's okay. There are a lot of resources for you, and talk to your doctor, talk to a pelvic floor physical therapist. We can help you. You're not alone. Millions of women are going through this at the same time. And, it's a roller coaster, but we get through it. We get through it together and being prepared with information and resources.
Yes.
So thank you for spending time talking about this. Just great information. Thank you for joining me for this session, and tune in next week for another episode of Ladies, Let's Talk About It.